Hi, I'm Dr. Richard Golden. I'd like to share with you another exciting video showing the extraction using the physics forceps. How predictable, atraumatic, and easy these extractions can be. So please watch and learn.
Today we're going to strategically remove some of our patients' teeth and place 4 dental implants. The ultimate goal is to fabricate an implant retained horseshoe overdenture, and the retention will be done with locator attachments. Now, one of the hardest parts for our patients is removing the teeth. Not only is it physically traumatic for the patients, or potentially physically traumatic, but much more emotionally traumatic. Losing your teeth, if you can imagine, has to be very difficult. We're going to be dealing with the upper arch, and we're going to again strategically remove some of the teeth so that I can place my dental implants, graft the sockets. We'll demonstrate simple socket grafting techniques with a couple different materials. But we fabricated a resilient flipper or removable appliance, transitional appliance, that will fit over some of his remaining teeth during the 4 months of integration. This allows the patient to be a little more comfortable having more stability, especially this particular patient who does a lot of speaking in school. So we're going to do this case in steps, basically. We're removing some teeth, we're placing the implants, we're allowing them to integrate. Eventually we will fabricate the maxillary implant retained overdenture. We will do wax setups around the remaining teeth. The day that we deliver the final prosthesis is the day that we'll remove the rest of his teeth. So if you look at the radiographs here, you can see we have some problems, a lot of periodontal bone loss. Tooth number 4, or the maxillary right second bicuspid, does have some periodontal defects and has a class 1 mobility. The other teeth that we're removing, the right lateral and central incisors, the left central incisor, and then the left second bicuspid tooth are stable. And we're going to use our innovative physics forceps to atraumatically remove those teeth, maintaining the sockets so that we can place dental implants in the number 4 area, or the second bicuspid area, the lateral incisor area on the right side, and then in healthy virgin bone on the right side. So let's get into the surgical suite and see what we're able to accomplish. I'm Dr. Tim Kaczynski, and today we're going to demonstrate some really neat techniques. We have Tom here sitting in the chair, and Tom has some issues with his teeth, some aesthetic problems, and came to us requesting dental implants. Now, we did a diagnosis, and we'll describe that in a little bit. We did a CT scan, so we know the positioning of the implants that we want. But the hardest part I find with our patients is not so much taking teeth out, because I think we're pretty good at that, nor putting implants in. We place a lot of implants, so we feel fairly comfortable with that. It's what does he wear during the healing process. He will end up with a maxillary implant retained overdenture when we're finished, but we have to allow the implants to integrate for about 4 months minimally in the upper jaw, in the maxilla. So what we decided to do was to strategically remove some of the teeth, strategically place 4 dental implants, and have him wear a maxillary flipper type appliance during the healing process. This will give him stability for that 4 months. The alternative is to take all his teeth out and either let him walk around without anything, or a maxillary conventional denture or a transitional denture, which would be much more uncomfortable for him during the healing process. So we agreed that this would be an ideal approach. He's a businessman, he has to speak, he teaches, and so he has to be able to communicate, and for his peace of mind and his ability to function appropriately during the integration or the healing process, we find that this may be a very excellent technique. We're going to remove 5 of his natural teeth. We're going to remove his maxillary right second bicuspid, his maxillary right lateral and central incisor, and also his maxillary left central incisor, and also his maxillary left second bicuspid. We're then going to strategically place 4 dental implants in the edentulous maxillary first bicuspid area, maxillary right lateral incisor area, the maxillary left lateral incisor area, and then the edentulous maxillary right bicuspid area. We're going to demonstrate some grafting techniques, socket grafting techniques in the second bicuspid area, and we'll show some grafting techniques in an immediate placement of an implant in the lateral incisor area, and then we'll graft the central incisor areas with a cancellous bone material, and we'll show how we do that. Socket grafting, I think, is very important to minimize bone loss and shrinkage during the healing period. So Tom is pretty numb. He knows that if anything I do bothers him, he'll let me know by raising his hand. So let's begin the process by removing the 3 maxillary right teeth that we indicated, and then we'll go to the left side, and then we'll graft and place our implants. What we're going to do is I'm going to remove the maxillary right second bicuspid area. Maybe it has class 1 movement. And the innovative physics forceps there's a variety of designs. There's 3 maxillary and 1 mandibular, and there are 3rd molar or posterior forceps, which is another kit. But here I'm demonstrating the use of a upper right physics forcep. And you can see by the design, the physics forcep has a beak, which is a flattened beak, which will engage the palatal surface of the tooth as far up the root of the tooth as possible. I'd like to go 2, 3, 4 millimeters up the root as possible. Then we have a bumper. The bumper has a little silicone piece that is easily placed, and we throw this out after each use, and the entire system can be sterilized. The bumper will engage the buccal or the facial portion of the tooth as far up the vestibule as possible, up at the mucogingival line angle as possible. So let's see if we can demonstrate it. Can I have a retractor, please? And what I'm going to do is I'm going to engage the palatal or lingual surface of the tooth as far up the vestibule as possible, and you can see the bumper is engaged on the facial surface. And what I'm simply doing is, no finger pressure here, I'm not really squeezing this forcep. It's kind of a unique forcep. All I'm doing is rotating my wrist, so there's no forearm, there's no pressure here, and I'm rotating my wrist, and you can see I'm barely holding on to the forcep. If you wanted to, you could pull it right out of my hand. I'm rotating my wrist, rotating my wrist, rotating my wrist. And it may take a minute or two, which is a long time for a dentist. And I'm simply rotating my wrist. The most important part of extractions, and you can see the tooth is giving a little bit, I think you can see that. And I'm rotating my wrist, rotating my wrist. Now the instrument is not intended to remove the tooth in total, so I'll take an instrument, a forceps, and I'll simply rotate. Now this is amazing. Look how skinny that root is. It has a little angulation in it. And we took a fairly difficult extraction and we made it very, very simple. Very skinny root. But the most important thing with this process is that we maintain the buccal plate. So if I wanted to put another implant in there, it would be much better prognosis maintaining the buccal plate. So let's move on to the anterior. And here the design is just a little bit different. It is a maxillary anterior, upper anterior, and they're all labeled on the forceps itself. But the same type of design. We have a beak and a bumper. The beak will engage the tooth on the palatal, 3 millimeters subgingival if possible. And the bumper will engage the vestibule area as high up the vestibule as possible, up at the mucogingival line angle. So again, I'm trying to do this on video. Can you hold it, please? And I'm going to see if I can use my left hand here just to engage it. So I'm engaging the beak on the palatal, and you can see I'm using my left hand with really just a thumb and a one finger, and I'm rotating my wrist. No arm pressure. I am not squeezing. You can see I'm just kind of holding the forceps gently in my hand and rotating my wrist. And it may take a minute or two, again, which is a long time for a dentist. And if you want, you can put a finger there just to stabilize it if you need to, but for video demonstrations, I'm trying to minimize that. And you can see the tooth starting to give a little bit, and I'm simply rotating. Simply rotating. And you can feel the tooth give. I'll go back to my conventional forceps. And the tooth is very loose, and we're trying to maintain that buccal plate. Now again, just amazing. Look at how long that tooth is. The buccal plate is totally intact. I can feel it, so I feel very comfortable doing an immediate implant in this area. See that angulation? Okay, 2 down. Tom, how are we doing?
Good.
Pretty amazing? All right. And let's do the central incisor. Same thing. I'm a right-handed dentist, so using my left hand is a little bit uncomfortable. But again, simply grabbing on. That slipped a little bit, so grabbing on and just using rotational forces. Not squeezing, using rotation of my wrist. Again, it may take a minute or two. Just be patient, take your time, and you get a very atraumatic extraction. Sometimes it helps to hum when you're waiting. My patients don't like when I sing. So again, I'm not using force. And you saw that tooth give a little bit. Simple rotation. See that tooth give? All rotation. No arm strength at all. And again, taking a conventional forceps. And again, I want to maintain that buccal plate. So just take your time. And just a perfect extraction. The buccal plate is totally intact. Makes for a very simple technique. Tom, are we doing okay? Beautiful. So you can see we did 3 extractions. One tooth, the second bite had a little bit of movement, but the lateral and central were very long teeth. So we removed the 5 teeth fairly atraumatically in a matter of minutes. The patient tolerated that procedure real well, very well, and so now we'll go ahead and we're going to place our implants and do some grafting. So what I'm going to do here is harvest some blood from the socket site, and I'm just using an insulin syringe. And in one of the sites I'm going to use tricalcium phosphate, which is a salt material. And the tricalcium phosphate we mix with blood. To wet it. It makes it a little bit easier for us to work with. And we can use this product. This is a wonderful product when you have a socket site. It is synthetic, so it's not human or cow bone, so our patients respond to it very, very well. And it will appear to be a little radio opaque when we first put it in, and it will change to a more normal bony look after healing. We all know that bone is a living organ, and it will turn over to form a nice bone. We'll also demonstrate the use of cancellous bone. This is human bone, process very safe, and works very, very well also. So we'll demonstrate the use of this in one of the other sockets. But let's go ahead and put our 4 implants in first, and then we'll demonstrate the grafting technique. Okay, so now what I'm going to do is place our dental implants, and the extraction in the second bicuspid area came out so cleanly and so nicely. I'm going to try to strategically place my 4 implants. Remember, what we're attempting to do here long term is it's going to be a maxillary implant retained horseshoe shaped overdenture. So I'd like to space my implants as much as possible. So let's do this. Let's go ahead and place the first implant in the second bicuspid area. Now, I tell my patients when we do an extraction, the tooth itself looks like is shaped like an egg, or the socket is shaped like an egg, where our implants are round. So we fill in the void with our bone building material, whether it be a synthetic or human bone, to fill in the gaps, sort of like caulking. And this will allow the area to heal, and it will prevent or minimize any shrinkage vertically and horizontally. We're going to be using the Glidewell Inclusive implant today, and I just want to demonstrate this kit just a little bit. We're going to start with like a lance drill that will make my initial penetration. Then we have a pilot drill that's 2.3 millimeters in diameter. And you can see here there's a little picture of the implant itself. It says 3.7. And from our diagnosing before we began, we decided that we were going to place 4 3.7 by 13 diameter 3.7 diameter by 13 length dental implants. And so you can see our drills. We have a 2.8 drill, and then a larger 3.4. And the size of the osteotomy is based on the quality of the bone. So for more dense bone, you're going to make a little bit bigger opening. And we'll demonstrate that in just a few moments. The important thing is that these drills or surgical burrs are undersized. They are slightly smaller than the implant itself, so you get great initial stability. Retractor, please. All right, I'm going to have you turn your head just a little bit. Tom, can you suction, please? So I'm going to go to the 2.3 diameter burr, and they are marked so we can see the depth of the placement. And I'm going right into the socket, slightly lingual to the socket. And I'm drilling at about 1,000, 1,100 RPMs, and I'm engaging bone. So that was a 2.3 pilot drill. Now I'm going to a 2.8 osteotomy burr. And I'm going to depth. This was the 2.8, it's just a little bit wider diameter. And then I'm going to, our final ostomy would be a 3.4. And I'm going to depth. You can see these burrs are very sharp, very efficient. So as we said, we're going to use our tricalcium phosphate material. And I'm simply going to use my instrument, and you can see it's mixed with blood. And I'm going to go to the socket site. And I'm just going to pack it in there gently. This will fill in the gaps as we talked about. Here's our Glidewell implant. You can see the aggressive threads and the carrier. And I'm just going to the site, and I'm simply tightening with finger pressure. And the little cap comes off. And we'll use our little inserting tool to hand tighten it a little bit more. And we will then go to our torque wrench, which will illustrate the amount of tightness that we're going to put this into. Now, if we get to 25 Newton centimeters, we'll put a healing abutment. If it's less than 25 Newton centimeters, we'll put a healing cap in there. And we're torquing that down to about 25 Newton centimeters. So our first implant is completed, and we'll move on to the second one. So here we placed one implant. I feel very comfortable with it, and I'm just putting a little paralleling pin in the implant. When we're doing overdentures, if we're going to use locator attachments, it's important that the implants be as parallel as possible. Remember, the remaining teeth will be removed on the final seating of the case. And so again, I'm taking my 2.3 pilot drill, and I'm trying to parallel it to the other implant that we already placed. Now, my positioning is slightly palatal to the socket. I am not following that socket hole because that socket, that facial bone, can be very thin. But as we demonstrated earlier, we know we have the buccal plate in position. We'll go to the 2.8, and again I'm watching my parallelism. And then going to my 3.4, or the last burr, to depth, and I'm gauging real good bone there. taking our second implant and engaging the bone. Cap just kind of snaps off. Then simply taking my hex tool and engaging, just tightening it. Now I didn't need to add any synthetic bone material in this site because the implant was about the same size as the socket itself. Okay, so number 2 is done. I placed 2 more implants in healthy virgin bone on the maxillary left side, but we still have 2 socket sites or 3 socket sites that are not filled. So what I want to do is demonstrate the grafting techniques that we use for socket preservation. This will minimize any future bone loss. And the first technique that we'll use is with our tricalcium phosphate material that we mixed earlier. So same technique, what I'm doing is simply taking the crystals, and we'll try to do one site at a time, and we'll place our bone substitute into the socket. Now you can see I'm not over pressing here, and blood is good. You want a little bit of bleeding there, and I'm simply condensing the bone but not crushing the particles. This will allow the bone to heal, and you'll see on the radiograph how that looks. So I'm not crushing the bone, I'm just using gentle pressure. Now this material is excellent when we have a 4-wall defect, or a defect that has all 4 walls, meaning a socket. It's a wonderful method of maintaining the socket site. So I'm putting it up to the crest of the ridge with some simple pressure. I'm just going to wipe it so you can see a little bit better. Now what I'll tell my patients is that these are little crystals, like little pieces of sand almost, and some of it may escape. But it's not harmful at all. This coagulates pretty quick. Now when we're doing a graft, we also want to place a barrier in the area. Now what we teach is if you can get complete closure of the socket, then we can use a resorbable barrier. If you cannot, then we'll use a non-resorbable barrier. And this is just one type of barrier that I will simply place into the socket site and kind of tuck it onto the facial bone, and then tuck it into the lingual portion. Give it a little squeeze there. And you can see our barrier in place, and now I'm simply going to suture that into position. And what I'll do is I'll just use a little cross stitch to lock it into position. Just so that the barrier doesn't move. And we know that tissue grows 10 times faster than bone. So the barrier, and I'll tell a patient, it's almost like a little band-aid that prevents the bone from, the tissue from invaginating into the socket. And make your nice knots, and simply snip that. These are vicryl sutures, which will be removed in about a week. And I'll just do another finish the cross. And it's just intended to hold that barrier in place. Just snip the whole thing, please. Snip the whole thing, please. So what I'm going to do is put our healing abutments in place, and because the tissue was about 3 millimeters in thickness and we were able to get to 25 Newton centimeters, we're going to go ahead and place our abutment. And it simply threads into the body of the implant. So what we're doing is putting in a healing abutment, and we'll torque these in and let the tissue heal around it. So what we have is, as we talked about, we use the innovative physics forceps to atraumatically remove our 5 teeth. We maintain the buccal plate of bone, which allowed us to immediately place 2 of our dental implants in the socket site. The other 2 were put in virgin bone. We demonstrated the surgical technique using the Glidewell dental implant, which are threaded into bone and torqued at about 25 Newton centimeters. That allowed us to put in 3 millimeter tall healing abutments, which should minimize the need or eliminate the need for a secondary surgery, meaning the tissue should heal around those healing abutments and we won't have to numb Tom again to be able to take our final impression of our denture. We will allow about 4 months for integration to progress. In the meantime, I can start making his immediate upper denture. And remember, our intention was to use the 4 Glidewell implants as support for locator attachments, which will then support an implant retained horseshoe-shaped overdenture, which will improve the quality of Tom's life dramatically. But one of the most important things that I mentioned early on was, what does he wear during the healing process? And because we're doing this in 2 stages, meaning I strategically removed some teeth, which allowed me to place the implants ideally where I wanted them placed, but I maintained some of his teeth, which will eventually be removed, to support a maxillary resilient flipper type appliance. And this will fit over his adjacent teeth. So let's see how this works for Tom. These are nice because there's no wires or clasps, and they're retained by the resilient acrylic, and we'll see if this will snap in easily for us. Oh, there we go. It's snapped in easy. Tom, can you put your chin down for me, please? And you can see, and if you could close for me, please, bite down. Then you have the retractors, maybe we'll see a little bit clearer. And we have open for me and close, and we have a nice restoration that he'll be able to function with fairly well, but more importantly he'll be able to do his speaking engagements, etc. Fantastic.